Well, good afternoon, everybody. I'm Steve Budd, volunteer for the Brattleboro Literary Festival, and of course, with me this hour is Ezekiel Emanuel. Zeke, in the introduction to your most recent book, Which Country Has the Best Healthcare? You tell us that you love ranking things, that you rank cheeses, you rank chocolate. Well, I just want you to know that I have posted in my kitchen your ranking of the most risky public behaviors that one can conduct in a COVID environment. So we're spiking a little bit in this neck of the woods, and that's my excuse for not getting a haircut for you today. But you're quick to acknowledge that there are many, many different rankings of healthcare systems, and none of them are great. And the upshot, I think, of what you're telling us is that you just can't decide what's the best healthcare system, and you say that you just can't decide what's the best and then plunk it down in the United States. And you talked about having to kind of think about any particular country's pathway in developing its healthcare system. So I'm hoping you'll tell us a little bit about that. You've written two new books, The $1 Trillion Revolution back in March, I believe, which was about your work with the Affordable Care Act, and Which Country Has the Best Healthcare System, which we're talking about today. For those of you who don't know Zeke, and that's hard to believe, but he is a special advisor to the Director General of the World Health Organization, a senior fellow at the Center for American Progress. He was the founding chair of the Department of Bioethics at the National Institutes of Health, and he's a member of the Council on Foreign Relations. He's also the chair of the Meta Council on the Future of Healthcare Committee for the World Economic Forum. He's the vice provost for global initiatives and the Diane S. Levy and Robert M. Levy University Professor at the University of Pennsylvania. I'll come back when you want me, Zeke.
Thank you, Steve. That was a lovely introduction. And I'm sure my mother will be proud. It is true. I love to rank things, and I've always loved to rank things. At the dinner table, my children used to chide me by throwing out some topic like schools and ask me to rank them, or presidents and ask me to rank them. And they would always, niggle me by throwing in some other thing that I hadn't considered. Interestingly, for a long time, over the last decade, audience members used to ask me, well, which country in the world has the best healthcare system? And I think deep beneath their question was the idea, well, why don't we just bring that here? We'll put it in the United States, and we'll have the world's best healthcare system. And they understood we didn't have a great system and it needed to be improved. I long resisted that question. I would poo-poo it by saying, look, we can't just take, call it Germany or France or Britain's healthcare system, pick it up and plop it down here. As Steve noted, there's a lot of history, there are institutions, it's very hard to undo. And then I would sort of say, look, there are a lot of rankings. I think some French researchers looked at all the rankings, and they came up with 9 different rankings of health systems. The granddaddy of them all is the World Healthcare Organization's ranking, which was done in 2000, had a lot of statistics and nice graphics. The United States came out in the 30s in that ranking, not very good. The ranking has a lot of things which make it unbelievable. One of which is, if you look at countries, there are places like Oman that rank higher than Germany, which is, kind of head scratcher. Certainly you could understand higher than the United States. And then some British researchers observed that the WHO ranking seems to be highly correlated with, they call it football, but what they meant was soccer rankings in the FIFA association. and that the higher your soccer ranking, the higher your health system ranking. And they said, therefore, the best way to move up the healthcare ranking was to have a championship soccer team. And that kind of put the end to that WHO ranking. And by the way, it's never been repeated since 2000, in part because there was this sort of dismissive research on it, and the results just didn't pass the sniff test. And many other rankings, don't agree at all. The second point I would make to people is that, the third point I would make to people, is that the problem is a lot depends upon what you actually think is important in a healthcare system. A lot of people take it as obvious, coverage and affordability. But the moment you begin to unpack these things, they're not so obvious. Like, does coverage mean universal coverage? But doesn't it also matter what services you are entitled to? How much your copay is? Does it cover long-term services? How is it actually doing in terms of quality, not just coverage and affordability? There's also quality. Does it have good mental health coverage? Is it innovative? Is it actually pioneering new ways, not just of treating people, but also of providing coverage, covering doctors? Is it not just affordable for the individual, but affordable for the whole society? You also might want to know how it's dealing with things like long-term care, drug prices, and other things. So a lot depends upon what combination of metrics you actually think is important. One of the things we ended up with in this book was 22 different metrics. So I'll get to at least one of the bottom lines in this book right now, which is we looked at 11 countries, Australia, Taiwan, China on the Pacific side, Canada to our north, and then across the Atlantic, we looked at Britain, a Scandinavian country, because liberals like all things Scandinavian, Norway. We looked at Switzerland because a lot of more conservative health experts say, Switzerland's a real idea. We looked at Germany, the Netherlands in particular, because of some other health policy experts say they've got a good example of managed competition. We looked at France, which came out with the #1 ranking in the WHO list, and of course, Britain. So we looked at 11 different countries. One of our bottom lines is the United States is not really in the top 10 of countries in world healthcare systems. Ours just doesn't perform that well. On the other hand, we're not the worst, and that may be reassuring to some of you. China is actually much worse, and its defects will become more obvious over time. For one thing, it is a totally hospital-centric system. It really doesn't have any physician offices outside the hospital. That is both inefficient. We learned that through COVID when they had to rapidly build, I think it was 13 hospitals in Wuhan to handle all the people because they didn't have other kinds of facilities. And it doesn't provide optimal care. Just when most of the world is moving away from more and more hospital care, China is focused on hospital care, and they have a very difficult time convincing people not to come to hospitals. It's going to be very difficult to make that transition. In addition, they don't have a very good long-term care plan, especially given the fact that with the one-child policy, you now have one daughter or daughter-in-law caring for 4 older people, which is going to make it enormously difficult going forward. So when we looked at various systems, obviously, from my perspective, one of the key things we were looking at is what could we bring back to the United States that would help us improve our system. We came up with a number of conclusions, but I do want to talk a little bit in depth about some of the countries we saw. One of the debates we've been having in the United States intensively is Medicare for all. And every time polling happens, people actually like going to Medicare for all until you tell them, well, that's going to require you giving up your private insurance. And then suddenly support plummets for it. It turns out you can get a lot of the advantages of a universal system and still retain private insurance. It's a sort of false notion out there. Well, if we go to universal coverage and the government's involved in the financing, we're going to go to single payer and we're going to go to socialized medicine. That's been a canard that has been perpetrated in the United States at least from 1946 on, when California tried to create a universal coverage system, and the opponents, led by the California Medical Association, labeled it socialized medicine. If you look at Germany and the Netherlands, those are two countries that actually provide the care through insurance companies. They call them sickness funds. Initially, they were organized around employers. So a big a Siemens plant would have one sickness fund, but now they've become slimmed down in more national organizations. There are about 105 in Germany and about 22 in the Netherlands. Basically, pay taxes to the government. The government then brings all the money together, adds a little of general revenue. Those taxes come from payroll taxes. Germany was the first to pioneer paying for health insurance through payroll taxes, just like we pay for Medicare through payroll taxes. And then they pay to sickness funds. When you select the sickness fund, they give a premium to the sickness fund. The sickness fund is allowed to charge individuals and families a little more. And that's the money they get to provide care. And the sickness funds organizes care. Now, in both Germany and the Netherlands, it might surprise you, they have more freedom of choice of doctors and hospitals than we do in the United States. In Germany, you can go to any doctor in the country and any hospital in the country, and you go to see a doctor, pay nothing. Zero deductible, zero copay. You could go to 10 orthopedists and have them look at your bum knee. You could go to 10 orthopedists in a day and have them look at your bum knee in Germany. Zero. It's remarkable, therefore, comprehensive benefits, universal coverage. You can see any doctor you choose, and it's very affordable at the point of care. It has a lot of ideals that we like in the United States. As a matter of fact, it has even one ideal that, it's been very hard for us to even get agreement on in society. Recently, they added in long-term care, again, through tax funding, so that there's a reliable financial basis for long-term care. But I brought up Germany mainly to focus on the fact that you can have private insurance compatible with paying the government, universal health care, comprehensive benefits, and free choice of doctor. So it's not necessary for us to go to Medicare for all if we wanted universal coverage, if we wanted to retain widespread doctor choice. There are other systems out there in the world that provide a good template for maintaining our private insurance system and getting to universal coverage with free choice of doctor. And Germany and the Netherlands are very, very good examples. And by the way, for those of you who are worried about affordability, and who isn't worried about affordability, those systems, both Germany and the Netherlands, are substantially cheaper than the United States. When we looked at it critically, the United States were spending 17.8, 18% of GDP on healthcare. Don't look, but it's $1 and every $6 in your wallet goes for healthcare. In Germany, it's about 11.5% of GDP, $1 in $10. That is a very big difference. And it's not the case that in either Germany or the Netherlands, there are long waiting lists. That if you need a hip replacement, you have to wait and wait and wait. That is true in a number of countries, Britain, Norway, Australia, but it's not true in these countries in Germany. So what does Germany or the Netherlands have that is challenging or problematic? Well, one thing, and a major issue in Germany, and a major issue they know about, is that they have too many hospital beds. As I mentioned when I talked about China, most countries have seen a decline in the use of hospital, a shift out of the hospital, whether it's to ambulatory surgical centers or more recently, much more care in the home. Germany has about 40% more hospital beds per person than we do in the United States. They find it very difficult to close down unnecessary hospital beds. And they think that has resulted in a lot of unnecessary medical procedures done in a hospital to keep those beds full. And that gets to the second point. The sort of monitoring of quality in Germany is not nearly as good as you might expect. Many of the German health policy experts are quite critical of the sickness funds, that they have not been good at monitoring quality and assuming that the quality and pushing to get the quality up. They also have a problem, or the doctors complain about a problem, that if costs are too high, they actually cut back what they pay doctors. So doctors might submit a bill for 50 euro, but in fact, because there's too many doctor office visits happening, that reimbursement to the doctor may be only 40 euro. And that happens after the fact, after they've seen the patient, when the sickness funds can see how much utilization there's been. And that's a bitter pill for a lot of doctors to take. So we went, as I said, around the world looking at alternative healthcare systems and looking what we could learn in the United States. One of the other areas we looked at was drug pricing and drug price controls. The United States stood out as a place for two things. One you know about. Really, really, really high prices. Our prices are way above any place else in the world, and we don't regulate prices. Every other country, whether you look at Australia or Britain or Germany or Norway, and even free market Switzerland, regulates drug prices. They recognize you give drug companies a monopoly by giving them a patent and marketing exclusivity. You can't let them set the price, because someone who has a monopoly will just put the price up and up and up until they're losing profits. And in the case of health, people will be willing to pay a lot of money to maintain their health. So all of these countries regulate drug prices. The second interesting thing, which again might surprise you, is they all have one price for a drug. They don't have a price for Medicare patients and a price for Medicaid patients and a price for patients on all the different kinds of insurances we have, and a different price for VA patients. They have one price in the country. And if someone has a large amount of use because they have a lot of illnesses, or they have a high expense for drugs will be harmful to them because they're low income, they subsidize the price. They do not make it a different price, because different prices encourages gaming of the system by the drug companies. And we see that a lot of that in the United States. Third, they determine a price by objective criteria. They often, almost all the countries, look at how much health benefit a drug is going to give you and then link that to the price they charge. The more health benefit, the larger the price. France has 5 levels of health benefit, and depending on how much benefit, you have a price cap on things. They also use these objective measures either by assessing as I said, the value, how much health benefit you're going to get, and linking it to the price, or they look around at all the other countries in Europe or Australia or other places and peg their price to other countries' price, so that they are not being abused the way we are in terms of having to pay much higher prices. Interestingly, the bills in front of Congress to regulate drug prices are not nearly as comprehensive as every other country we looked at in terms of drug pricing regulation. And we can learn a lot about effective drug pricing regulation in looking at these other countries. Well, COVID has exposed a lot of problems in our healthcare system, the disparities being a major problem. Almost all these countries make a very special effort to focus and target and make sure low-income people are covered and subsidized so they don't have to pay to see the doctor. The last point I want to emphasize, and this is dear to my heart, mainly because I'm the son of a pediatrician. My father was a pediatrician and took care of many, many, many children in Chicago. I can still walk into stores, and when they see my name, they say, oh, my son or my daughter or my grandson was a patient of your doctor, your father's. All these countries actually have children on health care, and they don't make parents pay the full amount. It is a very interesting phenomenon. So take Germany, for example. Germany is paid, healthcare is paid for by a payroll tax, but a worker pays the same tax regardless of whether they have a family or they're a single person. It's a percentage of their wages. And if a family comes onto the insurance, they don't pay more for the wife or the husband who's not working or the children. Children are free. Children often have additional benefits like dental care and vision care, which we included in the ACA. But the key message is they don't put the full financial burden for caring for children on the family. Children are viewed as a social responsibility, as something that we collectively as a society should support. And as a result, they tend to have better outcomes than we do, lower infant mortality and other outcomes. I think that there are a lot of things we can learn from other countries, and our book is filled with good lessons about how we can improve our system by looking at other countries. We're not going to take the German system and plop it down here, or the British system, or the Norwegian system, or the Swiss system, but there are a lot of lessons that we can learn from these other countries. Thank you, and I look forward to your questions. Steve, you got questions?
Okie dokie, Zeke. Well, we've got one question up here, and I think in part that's because I didn't tell the audience beforehand that the questions and answers were open. But actually, we've got a couple. So yeah, why don't we just start with the, do you see them also, Zeke, or is it only me that's looking at it?
Only you. You're the medium here.
All righty. Well, okay. So first one is a little lengthy. Joanne is asking us, why is the U.S. unable to negotiate uniform drug pricing? Pharma lobbyists? Question mark. And then she follows that question by saying, it takes 10 to 15 years to go from brand to generic. What are the alternatives in the interim when there's no comparable option to brand name drugs and insurance companies are unwilling to consider what is not on their formulary?
Well, that's a very good point. And the first thing to say is that, yes, the pharma companies are against drug price regulation, very strongly against drug price regulation. The dirty little secret is that they do expect to have some drug price regulation sometime in the future. They're working very hard on a COVID vaccine and COVID therapeutics because they want to get a good aura around them and halo and maybe put off the time when there is drug price regulation. But they expect something to be passed. The big question is when, but they are going to fight it tooth and nail, just like the cigarette companies fought tobacco regulation. The car companies fought, having a fuel economy and safety measures. The soft drink manufacturers fought against any sugar tax and things like this. They're protecting their business interests, and they make a lot of profits here in the United States. So it's interesting, if you go around to other countries, one of the things you learn is that they will give a premium for an innovative drug. But in some countries, the next drug, the Me Too drug, so if you have one, say, statin that reduces your cholesterol, that'll get a premium. When a second statin comes on the market, places like France say, oh, you can't charge the same price as the original. Your price has to be 5% lower. Or in Australia, they move the moment there's a second drug, even a second brand name, they move them to a new formula and they say 25% price reduction for both of you. So they have mechanisms when there are Me Too drugs in competition to lower the prices. Another thing they do is they often limit the annual increases that can happen. And they reevaluate whether drugs are really that beneficial after a set number of years. I think it's in Switzerland, it's every 3 years they reevaluate whether the drug is really that beneficial. Is its health benefits what were portrayed when it was being approved? And they can reduce the price if it's not that beneficial or if the drug company is making too much profits on it. Another innovation that has happened in this place, in Britain and France have sort of led this, which is they're looking at the total spend in drugs. And they say, well, here's our total spend. It can't go up. That total spend can't go up by more than 2% or 1.5% per year. These are brand new programs, and we're going to tax the drug companies if the total price amount spent on drugs goes up too much. That actually is a model that has been used to some degree in New York State's Medicaid program. We're going to cap how much the Medicaid drug budget can go up. If it goes up too much, we're going to recoup it back from the pharmaceutical companies. So there are lots of mechanisms we could adopt to actually lower price, even when the drugs are still brand name and not generic. I will say there is one place here in the drug ecosystem that the United States is a leader, and that is our generic drugs go rock bottom faster than any other countries. So we have lower generic prices, and we have lower, and they get lower much faster than in other countries. What we do badly is in the brand names. We don't, for example, I forget how many statins there are. Most of them are now generics, but at one time there were 8 or 9 branded statins. We didn't say, oh, look, there are 8 or 9. They're mostly Me Too's. We're going to bring the whole price down. That would have been the rational approach.
Thank you. Got a bunch of them here now, Zeke. Anne is asking us, well, it's a statement on a question, I guess. Children could be a priority, she says. How would we make that happen in the US? A healthcare challenge / issue could start in childhood and thus challenges adults.
Well, that happens now. That's no different now. What we could do is make, for example, employers cover families at the same price to the person as they cover individuals now. So let me give you a really concrete example. Individual insurance in the employer market. So if I work for the University of Pennsylvania, they provide my insurance. I'm an individual. It's about $7,000. I haven't looked exactly at what mine is, but that's what it is nationwide. And I probably pay about $1,500 to $1,700 out of my paycheck every month on that. I mean, every year on that. But if I'm a family, it's about $22,000. That might surprise you. It's enormously expensive to have a family insurance. And families pay substantially more, $6,000 to $7,000 to cover a spouse and children. And that, we could say, just can't happen. You have to cover the same price. Or we go to a tax system and we say, we're going to tax whether you've got a family or individuals the same, pool the money, and children are going to be covered by the collective payment, not ask the family to make an enormously expensive payment. We're often worried that having kids is too expensive for families. That's one of the reasons people think the birth rate might be going down. It is true. Kids are expensive between daycare and preschool and all the other food, clothing, etc., but also partially because they cost so much on the healthcare side. And we can ease that up.
Thank you. Being mindful of what you've said in your book, Zeke, about the healthcare system that we develop or that's developed in any country has to be mindful of the path that country has taken and what went before it. I've got two questions here that are similar, so I'm going to read you both of them. Bill is asking us, how do we move the USA toward a system like Germany's or Holland's? And for me personally, I'm not sure that's the whole universe of the kinds of questions we want to ask, looking at Germany and Holland. But Jim, where did you go, Jim? Hey, Jim, okay.
Well, why don't I answer this question while you're looking at the other? Okay.
No, he asked the same question essentially, Zeke. It's what obstacles do you see in the U.S. getting American healthcare up to the German level? So Bill asked about Germany and Holland, and Jim's asking about Germany.
So the reason I raised the Netherlands and Germany is because I think they're the closest analogy to what we will need, because I think Americans, for whatever reason, aren't so willing to give up their private insurance. And, we can try to psychologize it, explain it, call it irrational, call it whatever you want, but that's what the polling says. And the Clintons learned, try to get rid of the insurance companies, and they will fight you tooth and nail and torpedo your reform, and it won't pass. And so the question is, can we still work with them? I think they do bring something to the table. Can we work with them in developing a better, more effective system? So I do think that there's a positive answer there. Part of it is, let's look at Germany and the Netherlands, and then look at our unique situation and how can we do that? Well, one idea I've had along with my brother Ram, and we propose this, is, we have a problem with Medicaid in this country. It's 50 state programs, and there are 12 states that are implacably against expanding it, including and particularly Texas, Florida, Georgia, North Carolina, that have a huge proportion of people. And also, it might surprise the audience, a huge proportion of working African Americans. 46% of all African Americans of working age population live in the 12 states that don't expand Medicaid. It is impossible to get to universal coverage unless we get that Medicaid expansion. And those 12 states don't seem to want to expand Medicaid, no matter how financially advantageous it is for the states. So we've proposed, let's federalize Medicaid, make it one program nationwide. Well, there's a kind of grand situation you can create. If you've got Medicaid, 70, 80, 90 million people, because there are a lot more people are coming in because of COVID, because of becoming unemployed under COVID. You merge that with the exchanges, and maybe you even merge it with Medicare Advantage, the sort of managed care part of Medicare, which has become enormously popular too. You have a lot of people, over 100 million people in an exchange. You have the insurance companies have actually liked the Medicare Advantage exchanges. They've liked the regular exchange after some teething problems. And you could create a very efficient marketplace, kind of like Germany, where you get a set amount of money depending upon your income. You then select the insurance company you want. You give them the money. The government gives them the money, and they have to provide you comprehensive care, the 10 essential benefits that are part of the Affordable Care Act. That simplifies our system a lot. Either you have employer-sponsored insurance, you have traditional Medicare, or you're in this exchange and you've got choice, and you get subsidized to make a choice according to your income by the federal government. That actually makes it, we're not completely like Germany, but it's pretty close. And I think it would make it a lot, first of all, a lot simpler system, and would introduce a lot more efficiencies.
Inevitable that we would be asked to talk about this, Zeke, but what happens if we lose the Affordable Care Act? Karen asked us that.
Yeah, it is inevitable. So if you had asked that question of me in December 2019, I would have said there's no chance of losing the Affordable Care Act. The first thing to note is that the court case, California v. Texas, no reputable legal scholar thinks it has any merit. And I'm not talking about only reputable liberal or progressive scholars. I'm talking about no legal scholars, including the conservatives. There are a lot of conservative legal scholars who said this makes no sense. The basic argument is that if you take out the mandate, the whole Affordable Care Act has to collapse, becomes unconstitutional. It's an argument that was made by Anton Scalia in his dissents about the constitutionality of the Affordable Care Act. I just suffice it to say, constitutionally, legally, no one gives it credit. It has gotten through by luckily getting very conservative Republican justices, both at the district level and at the appellate level. Now it's in front of the Supreme Court. And before, when Justice Ginsburg was alive, I was pretty confident we were going to win because John Roberts was clearly on the side of upholding its constitutionality. If the Democrats take the White House and the Senate, there's a simple fix. And the simple fix is pass a law, a very simple law that says the mandate is severable from the rest of the bill. It what's called moots the Supreme Court case, makes it not relevant anymore. If we don't get that, if the Senate stays Republican, or God forbid, Trump wins, that was a political statement in case you didn't notice. And the Supreme Court rules that the ACA is unconstitutional, havoc will break out. Everyone has built the system on the ACA being there. And we should make quite clear, even if you don't personally get your insurance through the ACA, whether the exchanges or Medicaid, you will lose something. Let me just run down a brief list of things that go out the window. One example, there are roughly 3 million kids who are on their parents' insurance plan up to age 26. That goes. There are seniors, you're over 65, you get into that donut hole where you have to pay a lot of money. We close that donut hole, so you're only responsible for 25% of the drug bill in that zone. That goes. You get your preventative tests, your immunizations. So if you're older, you're getting your shingles shot, or kids are getting their immunizations. Now, today, no copay, no deductible. That goes. You get a mammogram or a colonoscopy. That is free, no deductible, no copay. That goes. So almost everyone has something that they're going to lose. And I've only begun to scratch the surface of many of the programs that will disappear if the Affordable Care Act is ruled as unconstitutional. And let me just be clear, and again, political. The Republicans don't have a substitute. It's not like they've developed over the last 10 years a very refined way of having a replacement for the Affordable Care Act that is more congenial to them. They've had 10 years, and all we keep getting is, oh, the dog ate my homework, right? President Trump says, I've got a great plan, and a great plan. Soon we'll release it. Well, soon has come and gone, and there's no great plan. And I'll tell you a secret as to why there's no great plan. Obamacare, the Affordable Care Act, originally came from the Republicans. The notion of an individual mandate, the notion of income-linked subsidies to buy private insurance, those are Republican ideas. They didn't originate with the Democrats. We took their ideas saying, listen, let's do it bipartisan, okay? You've been pounding these ideas for 50, 60 years, more than that, actually, if you want to be honest about it. Let's incorporate them and let's move forward to get to universal coverage. They refused, we adopted it, and they have no other plan. So it's not like they're going to rush in if it becomes unaffordable, if it becomes unconstitutional, with a plan that's going to protect you with pre-existing conditions. Yeah. So it'll be a terrible moment in American history. And I think if they rule it's unconstitutional, which would be a disaster, they're going to say, oh no, but let's not put it in place for a while. Let's give Congress a couple of years to come up with something in its place, because it would be so disruptive to the whole system.
You know, I think it's worth telling our audience. I might mention that I live in Massachusetts, and you know, I lived here, of course, under two successive Mitt Romney administrations, and of course, it was Mitt Romney, as you suggested, was the Republicans, and of course, in our state, you know, Mitt is a Republican, and he, you know, was the architect of our present health insurance system. And, you know, for you and for those who are listening, we like it. We like it. And, you know, I'm looking at the most recent question here about, is from Bill again, about, you know, why are they so fixated on rescinding the Affordable Care Act, and why won't they propose an alternative? And I guess, and you mentioned in your comments just a few minutes ago that I think that most egregious, I guess, is the mandate. And again, we are living under that mandate here in Massachusetts and are willing to do so. So yeah, go ahead.
There are two good points that you bring up, and let me just illuminate them a little more. The first thing is, you know, they got rid of the mandate in the tax bill. Went to zero, no penalty, so you didn't have to buy insurance. Guess what? People still wanted insurance. They still went to the exchange to buy insurance. And the reason there other 30 million people are still uninsured is not because they don't want health insurance. There is a small fraction of people who don't want health insurance and think they shouldn't have it and are willing to get sick and impose the costs on the rest of us who pay for people who are uninsured who get sick. But most people want insurance. They either find it unaffordable because they don't have enough subsidies, or they're caught. They don't get Medicaid, but they can't get in the exchange. But most people, you know, it's not the mandate that drove them. It's, if you give me the subsidies and they're enough for me to buy insurance, I will buy health insurance. I know it's important. There are some young kids who are, you know, in their 20s and think they're invincible, but that's not the 30 million people who are uninsured. It's a money problem. The second thing is Massachusetts is a standout state on this. You have been doing the exchanges longer, and you have about 97% insured rate. So that says that properly functioning, we can get up to 97% of people insured. Now, I might emphasize all the countries we looked at, but the United States and China, right? They're at 99.9% insurance. And by the way, in Switzerland, it's free market. You have to get insurance. There's minimal subsidies to people. There are subsidies, but they're not very generous. It's a private system. You have to select private insurance. It's not a exchange kind of arrangement. But Switzerland is very serious about its mandate. You don't get insurance, they know through your taxes and insurance company logs, they penalize you severely, basically the premium. And they, if after 6 months you don't do it, they render a penalty and they enroll you in insurance and pay for it and tax you. So you can be serious about this kind of mandate, and serious about the penalty and get to universal coverage, 99.9%, 99.5%. It's possible. Again, this is another lesson. Even with private insurance companies, there are ways. You got to be serious about it. You have to think health insurance, it's important to get, and we're going to force you to get it.
Thank you so much, Zeke. I mean, this has been very, very rich. So glad you could be with us. You know, not a night goes by that I don't see you on some news feed, or those that knew that I'd be talking to you today, writing me and saying, he's on this, he's on that. And I very much thank you for being out there. And I
Well,
really
thank you very much.
Thank you for
Wish
being
I
here
could
today.
wish I could be in Brattleboro in
Oh,
person.
yeah.
I love the literary festival, and it was when I got invited, it was a real highlight. And as I said at the start, we really wanted to be up there to enjoy the fall and to enjoy all the people who come to such a wonderful literary festival.
Yeah. Well, thank you, Zeke. It's been a wonderful weekend. The weekend was beautiful, but all of us are sitting here in our homes participating in this, and next year will be different.
Great. Look forward to seeing you.
Hey, thank you.
Take care.
Take care.